Once again, it's Friday, and everybody knows it's Friday. It's time to go inside EMS. I'm your host, Chris Cebollero, and with me always is the man of the hour, too sweet to be sour. The ladies know
Ladies
he's the
know I
man
have
with
the
the
power.
power, Kelly Grayson, KG. It's until I introduce you, don't interrupt me. Don't interrupt my opening. I mean, I've got to let it flow, man. Just like if I interrupt you in the close, it screws you up.
That's true. That's true. That it's tradition by now. I mean,
That's
it's
right.
it's a sacred custom.
We did talk when we were in Oklahoma, actually, to our friends in Choctaw, and a shout out to them, Choctaw EMS.
Yeah.
Um, we said that one show we're going to let you open, one show I'm going to close, and see how
Yeah,
that
we'll
goes
we'll
for,
have to do that, man.
we'll see how that goes for
I'll
you.
shock you.
Yeah.
I'll shock you.
You know, so we're always trying to think about some great topics that we can bring. And I got to tell you, one of the things that I have to deal with all the time is I have chronic kidney stones. Kelly, I know that you do as
A
well. And
lot.
you are a kidney stone producing factory.
Yeah.
Talking to people this week, I mean, there are two people I talked to said they're dealing with kidney stones. And I don't know why we're seeing more, or maybe we're just admitting that we're seeing them more. But one of the things that we thought we would do today is really kind of talk about the kidneys in
Yeah.
crisis, and how the anatomy really is something that we have to be able to pay attention to.
Yeah.
And, our role today is going to be to talk about some anatomy and physiology of the kidneys. I think we talk about some practical discussions, but, we talk a lot about hearts and lungs. And
Yeah.
really, when we think about the kidneys or any of those accessory organs, and I don't know that they're accessory because their functions are just as important as anything else, right? I mean, you can't
Yeah.
do your work, you can't do your body's work without these organs. Um, but we need to get lower in the body, and the kidneys really are two fist-sized organs that control more than you think. They control fluid balance, they filter waste, they regulate blood pressure, and a lot of people don't know that, right?
Yeah.
And then we think about the renin, angiotensin, aldosterone system,
Hmm.
and even more. The kidneys control red blood cell production, and when they fail, everything in the body starts to fail fast, Kelly. And I think that like I said, we spend a lot of time with the heart and a lot of time with the lungs, but the kidneys do a lot of I don't want to say damage, but that's where ACE inhibitors come from.
Yeah.
And the reason we take ACE inhibitors is because of what the kidneys do.
Yep. And when in EMS, we don't really pay attention to the functioning of the kidneys until everything goes south. But you mentioned earlier they are an essential element of our compensatory mechanism for shock in the renin, angiotensin, aldosterone system. I actually have an EMS conference lecture called the renin, angiotensin, aldosterone system. It's not just a planetary belt in Star Wars, but we don't pay much attention to the kidneys until they are not working right, or their compensatory mechanisms have failed, and the patient physiologically showing the fallout from that, the fluid overload, all sorts of electrolyte imbalances, altered mental status, and if you don't understand the kidneys and their role in fluid balance and compensation for shock, you're going to miss a big picture. So well, we'll talk about what the kidneys do, and
Yeah.
how they do it, and what happens when they don't.
Yeah, let's talk about I'll talk a little bit about anatomy if you want to get
Yeah.
into functions, Kelly. But we think about the kidneys, and they're one on each side in the retroperitoneal space, about 4 to 5 inches long. So
Yeah.
they say about a fist, right, is
Yeah.
about the size of your kidneys. And don't do that ever in front of a guy ever again. And but 4 to 5 inches long, and blood supplies from the renal arteries, from the abdominal aorta. And this is where the renal veins are involved to the inferior vena cava. And their functional units, they're nephrons. And we've always seen and talked about the nephrons, over 1 million per kidney. Uh, um, Glomulus, proximal distal tubules, loop of Henle, collecting ducts. Those are all part of the functional units of the kidneys. And they're probably about mid lower back. is where you could probably put those. So if you take your hand and if you put your hand behind your back and
Yeah.
wherever your fist lands is where your kidneys will probably be. So when you start to feel those
Yeah.
challenges, and if you've had kidney stones before, you know that they start high and then you could actually feel the stone move as it tries to move down. But when we think about this from an anatomy standpoint, the kidneys have a very, very powerful function in the body and do a lot of disruption when they're not working right. So let's talk about some of the pathophysiology, Kelly.
Yeah. Well, the when the kidneys focus or filter your blood supply anywhere from 20 to 30 times a day. Uh, they're not lying when they say the kidneys are the windows to the viscera. If you want to know how other organs are perfusing, one of the few things that you have to do is look at renal output, and that tells you a great deal about how well those organs are being perfused. Um, they filter and remove the toxins from the blood, but more than anything else, they help with fluid balance. And that old saying we've been teaching paramedics from time immemorial is water follows salt. And the kidneys and the various hormones that act upon them help maintain the sodium content in different places in the kidney. In the kidneys, you mentioned the distal and proximal convoluted tubules and the loop of Henle. Um, where salt stays, do we keep it in the collecting ducts or do we keep it in the blood vessels? Manages our fluid balance in the body. This is how loop diuretics like Lasix and Bumex work. Is they cause more sodium to be held in those convoluted tubules in the loop of Henle, and it draws more fluid to it, and you urinate that out. Whereas hormones like vasopressin keep it in the blood vessels and draw more water to that, and you pee less. Uh, they're amazing pieces of human machinery. They will regulate your glucose, your electrolytes. They'll move excess ions and acids and waste into the urine. They're a huge part of our maintenance of our acid-base balance. And you mentioned erythropoietin and such. They're going to maintain our blood volume and our pH and maintain our blood pressure through renin and the cascade of events that happen after that. Angiotensinogen, angiotensin 1, angiotensin 2, and so on and so forth. I think that I'm a big fan of knowing why things work. If you know how the body works,
Yeah.
what to do when the body is not working correctly is fairly straightforward after that point. I think it's essential in understanding what it is we do, and just as importantly, why we shouldn't do certain things. You got a CHF patient, fluid overload. Kidneys may be part of the problem. It's not so much that in fluid overload is not nearly as common as we might think it is. Quite often our patients in acute pulmonary edema are not suffering from fluid overload. They're actually relatively dehydrated. But the cascade of the angiotensinogen into angiotensin 1 and that kick-ass
Well, hang on.
vasopressor angiotensin 2
Let's be let's
that
be
is regulated by the kidneys is a big part of it. You get your dialysis patients that we see all the time that missed a session because they were sick and didn't want to go. They've got tremendous electrolyte disturbances. They're hyperkalemic, all sorts of electrolyte problems, and the shock patients. The kidneys are the first things to
yeah.
suffer from hypoperfusion because they have that juxtaglomerular apparatus that is one of the first mechanisms to sense hypovolemia and start a compensatory cascade for it. Once again, your kidneys are the windows to your viscera.
Yeah, well, hang on. Let's get a little bit more basic, right? So when we start to talk about, you said congestive heart failure. I just want to back that up a little bit because
Yeah.
when you talk like a Merck manual sometimes. And I want to really think about somebody has congestive heart failure because let's say they're having valve problems, right? So now what's happening is the body isn't pumping enough blood to I'm sorry, the heart isn't pumping enough blood to the body, right? And
Mhm.
now this is where we start to get the backup of fluid that'll go into the lungs and congestive heart failure, okay? More importantly, what's happening is the kidneys are down there saying, wait a minute, we haven't gotten our blood. We
And
need
their
we need
compensatory
we need our
mechanisms work against us.
right. We need our blood. So they release renin, which then transfers into angiotensin 1, which transfers into angiotensin 2. And this is a big vasodilator. So what's happening
Well,
is,
angiotensin 2, vasoconstrictor.
I'm sorry, you're
Yeah.
absolutely right. So it's a big vasoconstrictor, right? So now think about what's happening in the heart is that the heart isn't pumping and everything now is going to get constricted, which is now going to back up more fluid into the lungs. The
Yeah.
heart's going to work harder because the kidneys want their blood. They don't know what the heck's going on up in the, in that traffic flow of,
Yeah.
why is this traffic backed up? They just care. They just want to open up the highway so they can get the blood, which
Hmm.
now produces more fluid in the lungs, and now we have a bigger problem. So that's why people will take ACE inhibitors, the angio converting enzyme, and that's what converts angiotensin 1 to angiotensin 2 because they want to stop that from happening. The
Hmm.
kidneys will still release renin, but because people take an ACE inhibitor, they don't it doesn't get to angiotensin 1 and angiotensin 2, right?
Yeah.
That's a little bit more basic from what you said, but as you mentioned, reabsorption is big, secretion is big, the regulation of pH is huge, right? Now we start to think about metabolic and respiratory acidosis and alkalosis.
Hmm.
This is where the pH is regulated. Um, but one of the things that we need to start to think about here is now that we know a little bit of anatomy, now that we know a little bit of physiology, we got to recognize that early kidney related issues can prevent worsening in hospital outcomes. And we have to be able to be prepared for that. I feel like I'm babbling like you. Now I know what it's like when you babble, but what we have to
No,
be able
you'll
to
never
think
know.
about is EMS. We have to catch the subtle signs. One of the things that's pretty amazing is I have high blood pressure. And I don't know if we've talked about that before, but when I have to go to the bathroom 10 times a day, I know that my blood pressure is high and my body is releasing urine to try to help regulate my blood pressure. When
Hmm.
someone's in, intensive care and we have them hooked up to a Foley, they're measuring the urine output to see how the kidneys are working because the kidneys are really this big support of the rest of the body, right? So when you start
Yeah.
to see urine output or when you start to see dark urine output, that's not good of what's going on inside the body. So,
Yeah.
maybe we should take a deep dive, Kelly, or look at
Hmm.
some of the, acute kidney injuries, right?
Yeah.
And definition, I'll give you the definition. And if you want to give us some of the physiology of that,
Yeah.
pathophysiology. But basically, if we think about acute kidney injury, also known AKI, if you've ever heard it that way, it's a
Yeah.
sudden decrease in kidney functions over hours, over days. It leads up to a buildup of waste. This is where people start to get a little bit jaundice. And then you'll have some fluid into uptake as well as electrolyte imbalances. But let's talk about some of those types of kidney injury, Kelly.
Yeah, and it's often a tricky proposition to determine where this acute kidney injury originates from. It can be one of three mechanisms: pre-renal, intrinsic, and post-renal. And looking at their electrolytes and their clinical presentation often tells us. But basically, in broad strokes, pre-renal acute kidney injury is just from inadequate blood flow, shock, dehydration, that sort of thing. For whatever reason, there is not adequate blood flow to the kidneys, and they've sensed that lack of blood flow, and have released a hormone cascade to try to compensate for that. Now, in intrinsic acute kidney injury, there is something damaging the kidney tissue itself, the glomerular apparatus, the nephrons, and this could be glomerulonephritis, kidney toxins, rhabdo being the big one that we often see in patients with, for whatever reason, soft tissue damage. Can be from excessive exercise or crush injury or burns, anything like that that releases a large amount of myoglobin that will clog up those kidneys, can contribute to acute kidney failure or acute kidney injury. And the post-renal stuff is usually obstructive. You get something that obstructs flow of urine. This could be stones or an enlarged prostate or anything like that, and you're not excreting urine from the body, is the major element of post-renal acute kidney
Yeah.
injury.
Let me do a connection, Kelly, between how they connect to the anatomy and physiology. I think that
Yeah.
that's going to be important because I think now what we have to start to think about as clinicians is how do we understand anatomy? How do we understand the pathophysiology of how it functions? And now, as we start to get into these disease process, what part of the kidneys are having problems, right? So when
Yeah.
we think about it, the nephrons, which is the biggest part of that kidney, all these little tubules, they rely on constant blood flow. And that's kind of what we were talking about
Hmm.
before, right? And it'll filter, it'll reabsorb, but if it doesn't get its blood flow, it's, kind of acting up and it's going to start to do some things that may not
Yeah.
be great for the body. Uh, in the pre-renal area where you talked about, filtration will drop. And this
You still
will
have enough blood flow. Yeah.
right. And this will cause poor perfusion to the kidneys. And now the kidneys are running around saying, we need our blood. We need our blood. What are we going to do? From an intrinsic side or the intrinsic injury, this is really where the tubules and they start to get damaged. Filtration and reabsorption will start to fail. And so we know that there's an intrinsic injury. So now think about it as you start to go through your assessment skills and you start to see that, you start to see these symptoms. And Kelly, I think it'll be cool here in a minute if you talk about those field presentations of what those
Yeah.
clues would look like. And then, as Kelly said, in post-renal, this is where we start to see the prostate issues. This is where we start to see the stones, and women have stones just as much as men do, right? So this is a backup of pressure, and it damages the delicate structures inside those kidneys. And Kelly said before we started, as we were preparing to do this class, he probably passes 100. He's probably passed 100 kidney stones. That's a machine gun.
Yeah.
That's not a. That's a stone creating
A lot.
factory, right? But this will back up pressure, right? Because you're
Yeah.
not going to have the same urine output. Your kidneys are going to now start to expand. And there's delicate structures in there that are going to
Yeah.
be could be damaged and reduces output. But maybe you can connect for us, Kelly, some
Yeah.
of the field presentations that people are going to see when we talk about
Yeah.
these
Most
injuries
definitely.
inside the kidney.
Well, and back to my production of kidney stones. I haven't produced a kidney stone in a couple of years now, and it's all because I only drink one of these a day. And when I drink sodas, I drink I drink the clear sodas. It's amazing how much that does to reduce kidney stones. But when you see these patients with renal problems in the field, um, uh, you'll often see a sudden drop in urinary output, or no urine in the catheter bag, or that sort of thing. One of the most important history questions, for example, you can ask in pediatric patients and infants and toddlers is, how many times have you changed a diaper today? Because that sudden drop in urinary output might be one of the clues to why this kid is in shock or how deeply in shock they may be. You may
Hang on,
also see
Kelly. Hey,
edema.
Kelly, I don't
I'm
want to,
sorry,
I don't
what?
want to, I don't want to gloss over that because
Yeah,
that is extremely important, right? Because one of the things that we will use, and I'll hear paramedics have said in my career, how many diapers have you changed? But they're not really understanding the importance of that. But number
yeah,
two is we don't ask adult patients how many times they've urinated today,
that's
right?
true.
So we need to be able to add that into our assessment skill as well, because that's going to be an
Yeah,
indication of they're not passing urine, whether it's from a pediatric side, whether it's for adult side. But I didn't mean to cut you off. I just thought that that was an important fact to highlight.
yeah, yeah. And you may see the patient presenting with edema. Um, it could be peripheral edema in the extremities or the face. If you see facial angioedema, you got some major problems that are beyond just the kidneys. Or you may see edema in other places. Keep in mind now that this edema is not necessarily because of too much fluid, although in kidney failure it can be. But it can also be because of just improper distribution of fluid. These patients are going to have quite often elevated blood pressure or hypotension on the other side. Keep in mind that those compensatory mechanisms are increase vasoconstriction. Angiotensin 2, vasopressin, and aldosterone all contribute toward that. But if the kidneys are not filtering adequately, you're going to see some of the signs of these toxins building up in the blood: confusion, lethargy, nausea, EKG changes from hyperkalemia. And the thing they teach you in paramedic school to look for in hyperkalemia is those tall, peaked T waves. I'm going to say this right now. If you're looking at tall, peaked T waves for hyperkalemia, that's nice. Let's not do anything about it, hyperkalemia. When a patient is truly in life-threatening hyperkalemia, the EKG doesn't look like anything you've seen before. The QRS widens, your EKG almost turns into what looks like a pleth wave. And those are called sine waves, and that's life-threatening hyperkalemia, and you need to be able to do something about it. And there are a number of strategies we can employ as paramedics. But those EKG changes that they've traditionally taught us in paramedic school are really not the level of hyperkalemia that you need to intervene in any way. So keep that in mind.
Kelly, do us a favor. So let's talk about the assessment now, right? So we've done anatomy, we've done physiology, we've done a little pathophysiology as we got into kidney disease. So I think you really kind of laid it out for us well, where you said, look, here are some field presentations, but take them through an assessment. What would that look like?
When I'm assessing a patient that I often don't look for acute kidney injury. It's one of those findings that comes about through the rest of my assessment, and it's not the primary thing I'm looking for. But that's one of those tangents you often take. When I'm taking a history, especially of a dialysis patient, have you missed any dialysis appointments? Do you have any other recent illnesses? How much have you been peeing? Is there any pain with urination? Any burning? Looking for, say, UTIs. How much have you been peeing, or how little have you been peeing? What does the pee look like? We look at those things. Look at things that damage your kidneys, like NSAIDs, things that might interfere with your compensatory mechanisms, like ACE inhibitor drugs. Many of these elderly folks with blood pressure problem are taking ACE inhibitors, all those prill drugs that quite often they manage your blood pressure, but they also inhibit your ability to raise blood pressure when it's necessary. You look at their vital signs, blood pressure trends, any signs, any indirect signs of perfusion that we look at. We look at pleth waves. We look at the quality of their distal pulses. We look at if the patient is look at their capnograph waveforms and during a passive leg raise, those sorts of things. Look for signs of impending shock or volume overload, or the thing with the pleth wave and the capnograph waveforms, they can help you distinguish between a patient who needs fluid versus a patient who needs vasopressors. And above all, monitor mental status. Monitor mental status. We talked about the hyperkalemia patterns that you see. Remember that you look for those widening of the QRS complex, but mental status will tell you a great deal about a patient's renal function. At least give you some clues to start directing your assessment toward that, rather than just look at it as an isolated event.
Yeah. Well, there's poor blood flow. You don't know where it is, right? You have to be able now. This is where you become the ultimate detective of the body, that you're able to trend it, or that you're able to diagnose it right to the kidneys, whether it's the heart. I mean, so there are a lot of things that could cause mental status. But now, as we start to think about renal insufficiency and renal blood flow, again, that's where the other parts of our assessment have to come into play. And then when we think about it, usually I don't do a lot of clinical stuff, talk about it, Kelly, because you're more polished than I am.
Yeah.
I don't consider myself to be a paramedic anymore. I think I consider myself to be an administrator. But anyway, when we think about this from an intervention side, it's always support the airway, the breathing, the circulation, make sure that if there's someone's hypovolemic, we want to be able to give fluids. There are some people out there that are giving bloods. They're giving blood now, which I think is really important. If you're giving
Hmm.
fluids, you have to be careful not to give a fluid overload. So
Yeah.
let's think about this. Kelly, if I ask you, we have people that have renal insufficiency, and now we start to give fluid. What's fluid overload going to do here?
It's I don't know of it. Most patients, a judicious 250 cc fluid bolus or less than 500 is not going to cause overload. If you're looking, and make sure they can tolerate that fluid, listen to their lungs. And the pediatric patients, listen for the shift of the PMI. In other words, the heart tone shift to the left. But I am increasingly more and more likely to use a vasopressor than I am large volumes of fluid. One of the things that helps me inform my decision in that regard is that pleth wave variability, and if their CO2 exhaled CO2 comes up during a passive leg raise. If those things aren't present, it's not necessarily a fluid volume problem. It's a fluid distribution or a vasodilation problem. Of course, you're going to give them oxygen if hypoxic. If there are signs of hyperkalemia, and I mean signs of life-threatening hyperkalemia, QRS widening, sine waves, that sort of thing, you got to jump on the hyperkalemia hard. Calcium chloride or calcium gluconate. Bicarb is a temporary measure if at most. Albuterol is one of those things that really, really causes an intracellular shift of potassium within 5 minutes or so, and it will wear off shortly after you've stopped the albuterol treatments. But that's something that's often neglected. Give the patient a continuous albuterol treatment, and you can combat hyperkalemia fairly well. Or shift that D50 and insulin pump into high gear, because every molecule of glucose you move into the cell, it's going to take 4 molecules of potassium to accomplish that. So you can really do a lot for hyperkalemia by managing their blood sugar and getting it down to to an acceptable level. Get them to a facility that can do dialysis if you think that renal failure is a part of this.
Yeah.
And above all, avoid nephrotoxic medications in the field unless absolutely necessary. There are a few that we give that are nephrotoxic, but if you think somebody's having kidney problems, we kind of want to hold off on the steroids. You want to hold off on the NSAIDs like ketorolac.
Yeah. So I mean, hopefully we did this justice, Kelly. I mean, anytime we talk
Yeah,
about clinical topics, it's hard when you don't have slides and visuals and
yeah,
but hopefully we gave this some justice. But one of the things that you got to realize for all our peers out there is kidney problems don't just happen in isolation.
yeah,
They affect every other system. And we need to know how the kidneys work, how they're supposed to work. We need to know the anatomy. We need to know the functions, the physiology. And then we need to be able to look at the pathophysiology of the disease process and just relate it back to the anatomy. And I would encourage you to do that about any body system, right? Understand the anatomy, understand the physiology. And then when things are happening, what is being affected to cause this to happen? Even if the patient hasn't been diagnosed yet, which is sometimes people that we
yeah,
pick up, it's this is an acute action or acute disease that's happening. We've got to be the ones to figure out, and again, be the ultimate detectives of the body to make a determination of what's happening. Now, they're going to get to the ER and the doc's going to do his thing with them, but how
yeah.
cool is it if you can now know that this is secondary to whatever structure is being affected, Kelly. But, we used to say all the time, I think we have a clinical issue here.
I think we do. I think we do. And you made a great point. Kidney problems don't happen in isolation. I can't think of any of the patients I take out who are diagnosed with acute kidney injury where that is their primary diagnosis. They have acute kidney injury brought along by something else. But seeing that by itself in isolation is a rare event indeed. the whole purpose of this talk is not to turn you into a nephrologist. It's about recognizing the role of the kidneys in the patient presentations you see. It's connecting these dots and giving you some clues as to what is actually going on, how fluid status, blood pressure, mental status, as EKG changes, the indirect measures of perfusion that I talked about, pleth wave variability and increase in CO2 when you do a passive leg raise. All those things can help you determine whether they are in impending shock before their blood pressure drops out, or what might be the source of their inadequate perfusion. That way, when you get to the hospital, a clear focus picture from the moment you roll in is important. And when you can arrive at the hospital and have a general idea of what's actually going on with the patient, that increases your street cred quite a bit among the physicians and nurses you're handing the patient off to. So what I'd like to ask you guys is, have you had a call where kidney failure or a dialysis complication completely changed the picture? We'd love you to share those war stories with us, and we'd love to feature it on a future episode. Until next time, I'm Kelly Grayson, and thanks for Beth. Until next time, for myself and co-host Chris Cebollero, thanks for tuning in to Inside EMS, and we're going to catch you guys next week.
See what I mean about how the close, if I throw you off your feed, how that works, right? Yeah.
You
All
got
right,
me off my
everybody.
game, man.
We'll see you
got me
next
off my
week,
game.
everybody. Bye.